Now moving on to the second session of another paper presentation, I would like to invite judges as Dr. Ritesh Kumar Gupta, Professor, Department of Medicine, RML, Dr. Amit Kumar Sharma, Professor, Department of Medicine at Lady Hardinge Medical College, Dr. Priyanka Shukla, and also request Dr. Nishant Dev to kindly join here to judge the session. And faculty for the first free paper session, I would like ask them to kindly collect their mementos from the registration desk. Thank you very much.
For this session, I would like to invite Dr. Krishna for the presentation. Dr. Krishna.
Hello, good morning to everyone. My name is Dr. Krishna. I am PG2 from Department of Medicine, Santosh Medical College. Today I am going to give my views on the relationship of hypertension with insulin resistance. Hypertension is one of the most significant and escalating global health issues. Moreover, obesity and insulin resistance are now common in patients with primary hypertension, leading to further increase in cardiovascular morbidity and mortality. Insulin resistance is associated with decrease in sensitivity of muscle adipose tissue to insulin, a reduction of ability to produce glucose, and its increase in fat production in the liver. Due to importance of insulin resistance, early insulin resistance identification is of great value in stratification of the cardiovascular risk and further development of cardiovascular disease and prognosis. Our aims and objectives. The primary aim is to estimate the insulin resistance in study population, and the secondary aim is to estimate the insulin resistance in hypertensive and non-hypertensive patients, and its comparison of urine ACR with stages of hypertension. Methodology. It is a cross-section observation study. The study was done in Department of Medicine, Santosh, Ghaziabad, and the study population consists of all the patients who attend medicine OPD and IPD in Santosh. The inclusion criteria consisting of study population attending the OPD and IPD and age more than 40, both genders were included, and the known case of hypertension or linear dilated hypertension with normotensives. Exclusion criteria: failure to obtain an informed consent and age less than 40, and recent MI and recent strokes and recent surgeries or any chronic liver diseases, and exclusion of secondary hypertension by history taking and general physical examination. Methodology. Among 190 patients, we have taken 95 as controlled 95 as cases, and they have underwent a detailed history and examination. They underwent investigations like fasting blood sugar, fasting insulin level, and renal function test, and urine ACR, and fasting lipid profile. And by using a HOMA IR, we have calculated the insulin resistance. And the total study population was 190. The cases are 95 and controls are 95. And the males and females ratio is 84:106. The mean age we are in patients with hypertension is 53.74 plus or minus 8.29, and without hypertension is 54 plus or minus 9.03 years. In this, the distribution, the age is almost same in patient with hypertension and without hypertension. And in the figure 2, it shows that comparison of serum insulin and HOMA levels between patient with and without hypertension levels. The serum insulin and HOMA were significantly higher among the patient with hypertension than the patient without hypertension. And in the figure 3, we can see that the comparison of urine ACR in a patient with hypertension was significantly more in stage of stage 2 hypertension compared to stage 1 hypertension. In this study, the urine ACR was significantly higher in stage 2 hypertension compared to the stage 1, and the study shows the serum insulin and HOMA were significantly higher among patients with hypertension than the patients without hypertension. And similar studies were done which show the association of insulin resistance with systolic and diastolic blood pressure. A study from Hypsinic community history study and study of Latinos suggests the correlation between HbA1c fasting HOMA were significantly higher in patients with pre-diabetics, and the study to find the relationship between insulin resistance and hypertension was done. This study concludes that there is a stronger correlation between insulin resistance and essential hypertension, and also confirmed that insulin resistance was a major risk for metabolic syndrome.
Thank you. What was the pathophysiology of causing the insulin resistance in a case of hypertension?
Sir, patients will have more of a fasting insulin levels, and
It's okay. Why did you exclude recent myocardial infarction and stroke in your study? What was the reason for exclusion criteria?
because we are excluding the cardiovascular risk because we already established cardiovascular events and this we are excluding certain patients.
Any other reason?
In the exclusion criteria, you have kept secondary hypertension as a secondary hypertension you diagnose by physical and general physical examination and the examination. What all points for the secondary hypertension? Okay.
Why was the cutoff value of 40 years in the inclusion criteria? Why was the age of 40 years taken to be the cutoff for inclusion criteria? And what was the cutoff value of HOMA IR you find to apply insulin resistance?
The cutoff value was 0.5.
Okay. Thank you, Dr. Krishna. Next, I'd like to invite Dr. Visheshan.
Good morning, respected judges, seniors, colleagues, and juniors. I am Dr. Vishesh Goyal, PG resident, Department of Medicine, Lady Hardinge Medical College. I am giving my thesis presentation on the topic anti-diabetic drugs and their effect on body fat, an enigmatic relationship, which I have conducted under Dr. Ramesh sir, Dr. Anupam Prakash sir, and Dr. Priya Bansal ma'am. Now, anti-diabetic drugs are known to affect body fat and body weight. Some drugs like insulin and sulfonylureas may cause weight gain, whereas DPP-4 inhibitors are considered weight neutral. However, literature is silent on the effect of these drugs on body fat, body water, and skeletal muscle mass. This study is an attempt to unveil this relationship of body fat with anti-diabetic drugs. Now, the aim of our study was to determine the change in percentage body fat at 4 weeks and 12 weeks of addition of either sulfonylureas or DPP-4 inhibitors in type 2 diabetic patients who were already on metformin monotherapy. The secondary objective in this study was to determine the change in weight after 4 weeks and 12 weeks. Now, the study was conducted as follows. Patients who were attending the general medicine OPD and the diabetes clinic of LHMC and SSK hospital were taken. in those patients, patients who were on metformin monotherapy for more than equal to 3 months with an uncontrolled HbA1c of more than equal to 7% were taken as inclusion criteria. We applied the inclusion and exclusion criteria. Exclusion criteria included those patients who could not use the machine that we used for body fat analysis, and those who had any reason for body edema, like patients with chronic kidney disease, chronic liver disease, or heart failure. Patients who have fulfilled all inclusion and none of the exclusion criteria were taken. A percentage body fat and weight was measured at baseline. Now we divided the patients into two groups. One group was taking sulfonylureas and the other group was given DPP-4 inhibitors. Percentage body fat and weight was then again measured at 4 weeks and then at 12 weeks. Although the study is still ongoing, we have data for 19 patients, out of which 8 patients were males and 11 patients were females, with an average age of 51.6 years and a BMI on presentation of 27.8 kilograms per meter square. 10 patients were added on sulfonylureas, while 9 patients were added on DPP-4 inhibitors. This is the baseline characteristic where the weight in general decreased slightly from 72.5 kgs to 71.9 kgs. There was a slight increase in percentage body fat from 31.2% to 31.6%, and there was a slight decrease in average skeletal muscle mass from 27 kgs to 26.5 kgs, and a slight decrease in total body weight from 35.4 kgs to 34.8 kgs. This is a tabulated form of the patients that we took in our study, in which, again, 9 patients were on DPP-4 inhibitors and 10 patients were on sulfonylureas. We saw that in patients with DPP-4 inhibitors, there were 2 patients who showed an increase in body weight, 4 patients who showed who did not show an increase in body weight, which was determined to be 1 kg, 1 kg plus or minus, and there were 3 patients who showed a decrease in body weight. Likewise, in sulfonylureas, we had one patient who showed an increase in body weight, 3 patients who were neutral, and 6 patients who showed a decrease in body weight. Out of the 9 patients who were started on DPP-4 inhibitors, 22.2% patient had an increase in weight, 44% were weight neutral, and 33.4% had a decrease in absolute weight. Patients who had an increase in weight also had an increase in fat mass. This we are talking about the DPP-4 inhibitors. Those who were weight neutral had majorly no change in fat mass, or in one case there was an increase in fat mass as well. And those who had a decrease in weight had a concomitant decrease in fat mass or were fat neutral in one case. Of the 10 patients started on sulfonylureas, 10% had an increase in body weight, 30% were weight neutral, and 60% had a decrease in body weight. All patients who had either an increase in body weight or were weight neutral had a corresponding increase in body fat or fat neutrality. In our study, we found that DPP-4 inhibitors were weight neutral and there was no increase in body fat percentage. However, body fat percentage was increased in patients on sulfonylureas and who gained weight. The limitation of this study is that this study cannot be extrapolated at this point of time, and conclusion cannot be drawn for general population as the sample size is very small. We hope to present this data when the full study of 50 patients is done in the coming months. Thank you. Fat mass was calculated via machine via a process known as bioimpedance analysis. We have a machine in our department called the Accunic BC300. It uses bioimpedance analysis for calculation of fat mass as well as calculation of total body water and skeletal muscle mass.
What was the cause of pathophysiology? Why there was a weight gain in subgroup where the patient was on sulfonylureas in comparison to DPP-4 inhibitors? Why was there weight loss in a significant patients who were taking the sulfonylurea in comparison DPP-4 inhibitors?
Sir, this is a new finding that we found that out of the 10 patients, there were 6 patients who showed a decrease in weight. Their literature only says that sulfonylureas are associated with weight gain. So this is something that we have an eye on, and we are hoping to explain this after we are able to take all 50 patients.
So what is the type of study here?
Sir, the type of study is a follow-up observational study.
And how did you decide which patient to be put on sulfonylurea and DPP-4 inhibitor?
Sir, actually, because this was an observational study, we could not add the drug by ourselves. It was only on the discretion of the treating physician who added the drug, and we observed the patient after addition of that drug. We did not add the drug as part of our study.
Is the sample size of 50?
Sir, there are not many studies that have been conducted on this, so this was taken as a pilot project. And there are no studies on this in literature, actually.
Okay, thank you, Dr. Vishesh.
Thank you.
Now, next presenter is Dr. Nitesh. Dr. Nitesh.
Good morning, all of you. My name is Dr. Nitesh Shukla, PG2, Santosh Medical College and Hospital. My topic is iron profile in diabetic mellitus and its relation with HbA1c. First introduction, diabetic mellitus refers to a group of common metabolic disorder that share the phenotype of hyperglycemia. Diabetic mellitus has several categories, including type 1, type 2, maturity onset diabetes of the young, gestation diabetes, neonatal diabetes, and secondary cause due to endocrinopathy, steroid use, etc. HbA1c is glycated hemoglobin that is used as an indicator of patient's glycemic status over the previous 3 months. There is currently no evidence that HbA1c serves any physiologic purpose, and Iron deficiency is a condition in which the iron content of the body falls below the normal level. The first stage of iron deficiency is iron store depletion, in which the serum iron and transferrin saturation and hemoglobin level are normal, but iron storage is reduced or absent. The subsequent stage is iron deficiency without anemia, which is marked by depleted iron store, low serum iron, and transferrin saturation, but not anemia. Anemia due to the iron deficiency is further progressed stage of iron deficiency. It is distinguished by the lack of iron store, low serum iron level, and low transferrin saturation, in addition to low hemoglobin level. In a region where meat consumption is low, food is not fortified with iron, malaria, intestinal infection, and parasitic worms are prevalent. The women and children are disproportionately affected by the iron deficiency anemia. Serum ferritin concentration represents total body iron store. It is possible for the serum ferritin level to drop as a low 10 microgram per liter when a person has iron deficiency. In inflammation disorders such as rheumatoid arthritis, chronic kidney disease, and malignancy, the ferritin concentration is significantly increased. The normal range for the serum ferritin varies depending on the individual's age as well as their gender. Aim, effect of iron deficiency anemia of HbA1c in the patient suffering from diabetes mellitus. The objective is to observe and analyze the effect of RBC indices on the HbA1c in diabetes, to study how HbA1c is crucial marker for the diagnosis of diabetes and its deciding treatment plan. The study was conducted in the Department of Medicine, Santosh Medical College and Hospital, Ghaziabad, and study was observed in diabetes mellitus patient who was attending the medicine OPD of Santosh Hospital, and the study design is cross-sectional study. In this study, as we want to observe and analyze the iron deficiency anemia in diabetes mellitus and its effect on HbA1c. Therefore, in order to calculate the sample size, we need to have estimate prevalence of type 2 diabetes mellitus as well as prevalence of iron deficiency anemia in type 2 diabetes mellitus patients. To this reference, we have found that the past research have reported that prevalence of type 2 diabetes in India within a range of 1.9 to 25.2%. For the sample size calculation, we take upper limit of this range. Also, our research works says that the prevalence of iron deficiency anemia in type 2 diabetes patient was 67%. Methodology: HbA1c measured by the diet method, fasting MPP measured by the glucose oxidase peroxidase method, and ferritin fully automated bidirectional infrared immune assay, and percent of transferrin saturation, derived iron and TIVC value, and ferrozin method without deproteinization, and TIVC spectrophotometric assay. Inclusion criteria: HbA1c more than or equal to 6.5, and fasting plasma glucose equal to or above 126 mg per dl, and 2 hours plasma glucose ranging 200 mg per dl or above during on glucose tolerance test, and random plasma glucose ranging 200 mg per dl or above, where random is defined as a blood glucose without regards to time since the last meal. And exclusion criteria is failure to obtain informed consent, pregnancy, and type 1 DM. Result: out of 56 patients, 32 were diagnosed as anemic, hemoglobin less than 12 and less than 13 for females and males respectively, with a mean of 53, whereas 24 had a normal hemoglobin. Participants' mean age was 51.51 years old. Mean HB, HbA1c, serum iron level, serum ferritin level, and eGFR in our study population were 11.725, 9.166, and 66.91, or 291.003 and 67.321 respectively. In our study, it was found that 57% of patients had anemia, out of which 62 were normocytic, normochromic, and 30 were microcytic hypochromic anemia. And non-anemic cases were found to be 43%. The mean eGFR in the patient with anemia was 63.13 plus or minus 18.407, and non-anemic patient was 72.92 plus or minus 17.849. The relationship between the HbA1c and HB values was non-significant. P value is 0.09. There was a moderate positive correlation between eGFR and HB values. The relationship between hemoglobin and iron profile had a positive correlation. The P value is 0.00. No significant statistically correlation was found between the eGFR and type of anemia, which in our case was microcytic hypochromic and normocytic normochromic anemia. This is a graph shows the variable of anemic patients, and the variable are age, sex, hemoglobin, MCV, RBS, HbA1c, and retic count on serum iron level, and TIVC, transferrin saturation, serum ferritin, blood urea, and serum creatinine, and eGFR. And this is another graph showing the variable of non-anemic patients, number of 24, the variable are same. And this is a graph of variable of total patients. Total number of patients is 56, and the variables are the same. And this is the graph show the mean age of case control and case and control subjects. The blue color shows the mean age, and red color shows the standard deviation. And second graph shows the hemoglobin among cases and control subjects. This graph shows the showing mean HbA1c among the case and control subjects, and second graph is showing mean serum iron level among the anemic and non-anemic patients. Discussion: the HbA1c fraction of hemoglobin A1 is by far the most common form of this protein. During the glycation process, glucose in the red cells react with the N-terminal valine amino acids of the both beta chains and generate to albumin linkase. Not only it is considered to be a primary object of glycemic control, but is also utilized as a diagnosis criteria in the guidelines that have been established by the American Diabetes Association. In the beginning, individuals believed that glucose level were the sole factor that may influence HbA1c. On the other hand, a number of studies have shown that it is a raise in the conditions that are not related to diabetes. These conditions including hemoglobinopathy, chronic kidney disease, pregnancy, and nutritional anemia. However, the result of our research demonstrated that there is no statistically significant link between the HbA1c and anemia. Similar to our study, Faisal et al. Conducted a study that showed no statistically significant correlation between HbA1c and anemia in both sexes, with p-value of 0.001. This is a graph shows.
Dr. Saab, you just move down to your conclusion slide. Yours already time is over. Just conclusion slide, please. Over. So you just tell me the normal correlation between the what happens to HbA1c level in anemia, severe anemia patients.
In my studies, sir, there's no significant changes in anemic patient and HbA1c relationship.
Overall, what is the correlation between in what happens to anemic patients regarding the HbA1c levels?
Some studies show that कि in iron deficiency anemic patient में HbA1c is higher side. But in my studies, because of sample size is small and that is at primary stage, and further so further इसको भी study की need है. So in my studies, there is no correlation between the non-anemic patient and क्या कहते हैं anemic patient and HbA1c.
Hello, there's a question. So did you classify anemia into different categories to see the effect of severity of anemia and HbA1c level?
So, ma'am, in male hemoglobin less than 13 and in females hemoglobin less than 12. That is the criteria for anemia.
We are concluding the session. I think this was the last presentation.
Thank you, judges, for conducting this free paper second session of free paper presentation. So I request all the faculty for this session to collect their mementos from the reception desk, please.